And thank you so much for the CAHO group and the KINPRO group for giving us a chance to present our study in this prestigious platform. I'm Dr. Faisal from Kerala, Aster MIMS Kottakkal, and my study is on percutaneous endoscopic lumbar discectomy, improvement in quality of life in patients on the basis of patient selection, satisfaction, and recovery. And the contents will be discussed under the following headings. And introduction, as we all know, low back pain is a major clinical problem which impacts a very adverse socioeconomic burden to the society. And in spite of all the technical and therapeutic advances in the diagnosis and treatment, we still have an increasing number of low back pains every day in our clinics, as we all know. So percutaneous endoscopic lumbar discectomy, it is either PELD, is done under local anesthesia, which is now the current flagship of minimally invasive transfemoral decompression. It was way back introduced in 1983, went a lot of changes and developments, and now we have two established systems called the Jung endoscopic spine system and the Gore's transfemoral system, which has made alternatives for open surgeries very feasible. And our definition for the problem was that the patient apprehension towards open surgeries and the complexities of anesthesia in patients with multiple comorbidities, including diabetes, hypertension, chronic kidney disease, stroke, CAD, in whom general anesthesia will pose a very significant risk, has led us to conduct a review on how the endoscopic technique differs from the conventional open lumbar discectomy in terms of the patient satisfaction and acceptance. So the diagnosis of the problem was, we started the study in 2018 September. It was a prospective study, and up to 2019, we could complete around 230 cases. So we started to, decided to go ahead with the prospective study. And all the cases were lumbar disc prolapses with either paracentral or central herniations, and chart reviews, preoperative and postoperative reviews were done on clinical parameters. And patient satisfaction was defined as a maintained reduction in pain and absence of recurrence within preceding months with no further surgery being necessary. As we all know, the PELD endoscopic discectomy has mainly two advantages. Firstly, it is done under local anesthesia with an awake patient, which allows communication with the patient and the surgeon during the procedure, and thus reduces very important, significant intraoperative complications like nerve injuries. Secondly, the approach-related complications like the dural tears and the CSF fistulas are minimized in patients with undergoing PLD. So just a few slides regarding the clinical tool mainly was the SLRT, straight leg raising test, and the Gore sign. I would enlighten a little on the Gore sign, where a Gore sign was nothing but elicitation of tenderness in the sural nerve at the posterior part of the heel, where S1 radiculopathy could be delineated, and elicitation of tenderness of the deep peroneal nerve in front of the ankle, lateral malleolus, would elicit a L5 radiculopathy. This was one of our major clinical tools, and the procedure is done under local anesthesia with the patient prone and awake. It's done to a percutaneous technique where the needle is introduced from the flanks around 13 millimeters from the midline, and the standard transfemoral scope with a single channel and a 3-chip camera is used for the procedure. And there's an intra-endoscopic view where you can identify the prolapse disc. The annulus here on the view is being cut with an RF factor or scissors, and this material is being pulled out. And this is one of the slides where you could recover almost 5 centimeter long disc material, and the patient, and you end up with the surgery with a scar nothing more than a 10 millimeter scar. So it's, to be precise, it is 8 millimeter scar at the end of the procedure. So the problem remedy, the patient apprehension towards open surgery can be overcome by this procedure. The patient and even the relatives are more comfortable being the patient in a conscious mode and more receptive to the procedure. An awake patient provides an excellent neuromonitoring during the procedure for the surgeons and thus avoids neural damage. The complexities of general anesthesia in patients with multiple comorbidities are reduced, and the post-operative period is absolutely uneventful, and the patient is ambulatory immediately post-op. And locking the improvement in primary disc surgeries in our center, considering the better clinical outcome, we have almost replaced most of our open surgeries with PELD, and thus reducing the involved morbidity of an open surgery. And in revision surgeries, we are very happy to go ahead with the PELD surgery, especially if it's our revision or a revision coming from outside. The surgeon can undertake the procedure with peace and ease of mind because the neural structures are never opened from the midline. And cloning the improvement, considering the benefits of PELD, we have extended the similar procedure to multiple levels, including the thoracolumbar junction, T2, L1, L1, L2, and L2, L3 higher up lumbar levels, especially utilized for biopsies and cultures from the disc and debridement in TB discitis, pyogenic discitis. We started utilizing PELD as an adjuvant in minimally invasive spinal stabilization for disc preparation and cage insertion. And we are in the near future, we are planning to extend this procedure to the cervical disc prolapse as well. And data analysis, we had 230 cases, male were predominant, and the mean age was 45 years plus or minus 13. And we had 2 cases of Kottakkal, 10 degenerative canal stenosis, and all our cases were done under epidural anesthesia, that is 71%. And few of them, that is 28%, we augmented the local anesthesia with epidural analgesia with bupivacaine, where we had to go trans-iliac route for L5S1 level. That was only level where we had to augment with epidural. All others, we had a local anesthesia in hand. And the right side was little predominant in our study, and the level was, the commonest level was L4, L5, and the Gore sign was positive in all our 100% of our cases, which came down negative to in 92% of the patients post-op. Only 7% showed a mild positivity post-op, which disappeared eventually. And data analysis, this was a female ratio. And
you have 1 minute to conclude.
Excuse me? Yeah, ma'am. And coming to the, we have done a paired t-test pre-SLRT and post-SLRT and got significant improvement results in the post-SLRT values. And tangible results, we could include patients with comorbidities, shorter operative time, reduced blood loss, the hospital in-stay was reduced, and the expenses of the hospital was reduced because of the procedure. We could demonstrate disappearance of Gore sign on table and also demonstrate live Valsalva maneuver on table. The improvement of SLR was palpable immediately post-op. Unsupported walking and voiding of the urine within 1 hour after surgery, and no need for ICU weaning. And intangible results were the patient could resume the work within 2 weeks after the procedure. There was minimal post-op pain and morbidity, extremely good satisfaction and acceptance from the patient, and early recovery, and good cost benefit because the discharge happened within 24 hours and almost few cases as day care also. And the next year, I would say that we had good follow-up up to 2 years, and we have 90% reduction in pain. That is successful outcome. 3 cases of discitis came in the way, which we could manage, and dysesthesia was the only complication in our series, and the pre-operation rate was similar to other published studies in the group. And this is comparison with other studies which happened in the decades behind, in the same decade, and we got similar results and almost good results.
All right, thank you very much for a very lucid and
Thank you.
Thank you very much for a crisp presentation. We will take 3 questions on this particular presentation. I'd first like to start with Dr. Ramesh Babu. Dr. Ramesh Babu.
Yeah, Dr. Faisal, that was a good presentation. I just wanted to ask, was the team comprising of only spine surgeons or orthopedicians as well?
Neurosurgeon was also in the group, sir. Our neurosurgeon was also there. It was a team.
Okay, thank you.
Dr. Mundkur, you have a question, sir?
Dr. Faisal, fantastic presentation as well as a fantastic job what you have done in your hospital. My question is, you assess patient satisfaction through 2 measures, improvement in pain and recurrence of the symptoms.
That's right.
Right. Now, how recurrence of symptoms can be a measure of patient satisfaction? Patient has undergone only 1 surgery. He has no experience of the conventional surgery done for this.
It's regarding the pre-op symptoms and recurrence of the same symptoms after the procedure. So
absolutely.
If the patient comes
absolutely, that should be your satisfaction. How you have improved versus conventional surgery rather than patient satisfaction. It should be a surgeon satisfaction rather than a patient satisfaction.
Probably, sir.
A patient will not know what is the percentage.
Actually, our aim was to conclude about the patient's pain pre-op and the recurrence of the pain if at all it happens. So success rate was based on whether the symptoms recurred after a few months.
That's what I said. The success rate is for the doctors rather than for the...
All right. I think Dr. Mundkur, your point is well taken. I think Dr. Faisal has taken that point in consideration. And we'll take 1 question from Dr. Sangeeta Kamachi. Dr. Sangeeta?
Yes, Dr. Faisal, that was a very new technique that you have demonstrated, but I just want to know what is the case selection that you do for these for this technique, and like Dr. Sunil was mentioning, what is the comparative feel that about surgeries prognosis afterwards?
Mainly, madam, we considered 3 aspects: the comorbidities in the patients, where the patient was denied of surgery because of the morbidity risk of GA, where a lot of centers have denied surgeries. We could take up these patients for this procedure. Otherwise, the results are almost at par, especially the patient's ease of acceptance was extremely good in our series, because the moment we introduced to them such a, there's a local procedure which you can undergo for the spine, the acceptance rate was much higher in our group, where that was the main thing, man. And pain extra, the evaluation pattern, everything was the same. The radicular pain, MRI evaluation findings, everything was almost same with even the open procedures.
So you only selected those cases which are not feasible for the J or are high risk for GA?
No, we could, now we are doing almost all cases with PLD only, madam, because the patient is coming for that. So patient really wants the procedure done.
All right.
All right. Thank you.
Thank you, Dr. Kamachi. Thank you, Dr. Faisal.